Good afternoon, everyone. I am Tiffany Marley, Project Director for the Learning Communities Resource Center, and we are excited to welcome you to today's Webinar Wednesday, which is entitled Impact and Evaluation for the Social Determinants of Health. This is a part of our Health Intersections Learning Community Group, so we appreciate you joining us today. During today's session, if you're having any technical difficulties with accessing today's webinar, we ask that you just utilize the question and answer feature to let us know what is going on with you, and we will troubleshoot that for you as soon as possible. Otherwise, if you have any questions for the presenter or for us today, we ask that you use the chat window to offer those questions or comments. Today's session will be an interactive one, and so there will be several questions that we will ask of you, and we ask that you go ahead and locate that chat window and be prepared to offer your responses in that, that function, in the chat function. So with that said, I am pleased again to kick off today's wonderful expert-led presentation and would like to ground our conversation in the promise of community action, which says, community action changes people's lives, embodies the spirit of hope, improves communities, and makes America a better place to live. We care about the entire community, and we're dedicated to helping people help themselves and each other. So may this serve as our North Star as we're thinking about today's conversation, but most of all, as we think about what we do as a network every day. So with that said, I would invite our attention to our agenda for today. I'm going to provide you just a little bit of information about the learning community, introduce our wonderful presenter and subject matter expert, and then you will receive today's presentation on impact and evaluation for the social determinants of health. We ask that if you have questions, raise those questions at any time during utilizing the chat feature, and by the end of today's presentation, we will dedicate some time to responding to those questions and engaging you in further conversation, and then we will provide you with an update on upcoming webinars and activities with the Learning Communities Resource Center. So with that said, just to familiarize those of you who are new to the learning community, our main intent is to build the community action network's capacity to fight poverty more effectively. We are in the anti-poverty business. It's really the heart of what we do and who we are, and through our work with the learning community, we aim to expose all of you to those promising or innovative practices, resources, information that help you to engage in that overall evaluation and set those outcomes and engage in those practices that really improve outcomes that relate to the causes and conditions of poverty. And so with that said, I would point us to our National Community Action, or CSVG, theory of change, and that theory of change aims to mobilize our entire network, be it local agencies, associations, or state offices, really all of us, to mobilize communities to fight poverty effectively, and we attempt to do so on the family and the community level. And there are several strategies that you see under services and strategies that really touch on a lot of the key topics that we address within the context of the learning community, which we think that if we engage in these practices in a comprehensive manner, that the lives of the families and the communities and individuals that we serve will be improved. And so with that said, you see on that services and strategies spectrum that helps social behavioral development. So it very much aligns with the focus of this learning community group and particularly today's presentation. And so then as we look at the next slide, here's a listing of all of the learning community groups that are available through our project, and you are more than welcome to take advantage of all of the resources available through our webinar Wednesdays and through our other web platforms that highlight resources, webinars, and other information. And ultimately, our goal is that as we're doing all that we're doing, they in isolation appear to be small acts, but cumulatively, as we are looking at the ways in which all of these factors sort of play into the overall well-being of individuals and families and communities, there's a potential for huge impact, and we appreciate you playing a part in that. And here is a picture of our national learning community. We span 33 states, 407 counties within our country, and all 11 of our regional performance, I'm sorry, our PIC regions. I'm about to mess that up. And here is our LCRC team. I've already introduced myself. Joining me today is my wonderful colleague, Liza Porras, but really it's all the people that you see pictured there that play a vital role behind the scenes in making this learning experience happen for you all today. And so with that said, it is my great pleasure to introduce our subject matter expert, Dr. Dayna Long. She has been and continues to be the subject matter expert for the Health Intersections Learning Community Group, and she works for the Department of Community Health and Engagement at the UCSF. I cannot say this word. Dayna, I'll let you say it, but the Benioff Children's Hospital. She's located in Oakland, California. I'm going to get a little more coaching on how to say these things properly, but what I can say is that Dr. Long is really a champion as it relates to transformational health strategies that move families forward, and it shows in her research and the care that she provides to her patients and the way that she has demonstrated herself as a colleague to all of us in the human services and medical field. So we appreciate you joining us today. We're going to hand off the baton to Dr. Dayna Long. Thank you so much for joining us.
Hello, everyone. I hope that you can hear me okay. Thank you for the great introduction, Tiffany, and it truly is a pleasure to be consulting as a subject matter expert on these webinars. And this is one of my favorite subjects to talk about. So we're going to talk about impact and evaluation for social determinants of health. Along the way, we're going to have multiple questions for the audience, so I really hope that this can be interactive. My title is quite a mouthful. So as Tiffany said, I am the medical director at the Department of Community Health and Engagement at the University of California, San Francisco, Benioff Children's Hospitals. And this webinar comes out of the experience that I've had over the last 2 decades working within a community-based hospital that also has an academic affiliation. As Tiffany mentioned, my background is that I am a primary care pediatrician. I'm going to turn my camera on so you guys can hopefully see me. I am a primary care pediatrician within what we call an SQHC, which is a safety net clinic. Of the patients that I see, 98% live at or below the poverty level, and 90% of our families are also families of color. It's been really important as we think about how to be innovative and disruptive within the space of equity and health disparities to be able to be as rigorous and intentional as possible to generate an evidence base that not only changes clinical practice systems, but also can be used for evidence-based policy. as I go through our agenda today, I really do want any of the attendees to please put a question in the chat box and ask me. So today we're going to talk about, is it worth it? Is it worth it to invest in evaluating programs and demonstrating impact? We're going to talk about how do we ask questions for social need interventions, various strategies that can be used, and what resources are needed in order to actually pull this off.
And I just wanted to start, I know that Dayna, you wanted to kind of get a sense of where everyone was at before we move forward with the presentation. So just to give you that context, if people want to share in the chat box where they're at in regards to some of these things that Dayna said we would be talking about today, really just why you chose to attend this webinar in general, and where you're at in terms of providing programs and services that meet the social determinants of health or screen for social determinants of health, and particularly if you're doing any evaluation around those efforts that you started. So if you just wanted to share in the chat box, we can kind of give Dayna a sense of where you guys are at, and so we can make sure that the content she shares today meets you guys where you are in providing these programs and evaluating your programs.
Thank you so much. So I'm going to start with a little story. About 6-7 years ago, when I had really shifted my clinical work from focusing on the emergency department and a lot of asthma research, and I was wading into the waters of social determinants of health, I went to a conference that was sponsored by the Center for Disease Control. There were a number of grantees who were attending this conference, and we were really appreciative to have received a grant called a REACH grant, which is Racial and Ethnic Approaches to Community Health. And that was the seed funding to launch initiatives to allow us to address the determinants of health universally within our medical, within our clinic. And I remember there was a session where we were talking about what does impact mean in the social sector. And oftentimes impact is demonstrated by saying, well, there was a smoking cessation program and there were this many attendees who heard the education. And oftentimes also impact is narrative, saying that this was the experience of the attendees when they went to that tobacco cessation program. And I think that that information is very good information, but how do we actually pair our academic institutions, such as, these leading academic centers, to allow us to more rigorously evaluate programs within the social sector? So I asked the question about what is the role of evidence-based science for the public health field? And the answer that I got was, well, things like randomized controlled trials don't really belong within the social sector. And I quite frankly disagreed, because I actually think that in order to be most successful, we actually have to marriage what we think of as rigorous science with social impact. And so that was really the impetus for my journey into this space. So when I am asked, is it worth it to evaluate, the answer is heck yeah. We really need to have evaluation and program development go hand in hand in order to demonstrate the value of the work. I also realized that there's a huge cost for evaluation, and that cost needs to be built in to program development from the very beginning as you actually are doing the ideation for what is the program that you're doing. And this field, we used to call it translational science. Some people call it transformative science. It's also known as implementation science. And what implementation science requires is really that transdisciplinary research teams work together. And this is very unusual for those of us in healthcare, to be willing and vulnerable and bold enough to get out of our silos. But we need to work together with academics, with clinicians, with economists, with social scientists, and with community-based organizations. So implementation science is really the scientific study of methods to promote systematic uptake of research findings and other evidence-based practices into routine, standard, traditional practices, and hence you improve the quality and effectiveness of the healthcare system as a whole. And implementation science plays a really important role in identifying barriers to and enablers of really global health programming, policy making, and it leverages the knowledge that's developed in order to be innovative. So where do you start? And you always have to start with a question, right? What is it that you're trying to answer? In the collective impact work that I do, we always say that you start the work not with an answer, but with a high quality question, and it's the quality of the inquiry that actually helps to drive the process. So in order to decide what your question is, you need to say, what is my specific concern? Is this concern potentially answerable? And making your question not so broad that it's just too big. So an example of a question that I currently am working on are, do adverse childhood experiences actually lead to poor health outcomes in children? So once you get your question, you can start to think about, well, what's my methodology in order to answer that question? And there's a broad range. Tiffany, if there's any comments along the way, I saw some things sort of flutter up in my chat box, just stop me. One of the simple ways to answer a question is to do a chart review. And chart reviews are fantastic for quality improvement. Chart reviews either can be retrospective or prospective. So a retrospective chart review, it basically evaluates patient data that is already existing at the time that the project is starting. So one of the retrospective chart reviews that my team was involved in a while ago was looking at, are we actually documenting levels of asthma control in the patients that we saw within our clinical setting? Simple question, simple way to answer it. A prospective chart review evaluates patient data that does not yet exist at the time the project is starting, but will be because of the project. And an example of this is that I was talking to our emergency department staff just yesterday, actually, and they want to be able to make sure that they're documenting any kind of social history in the notes that are generated by physicians in the emergency department. And so they're going to choose a template for that social history and then prospectively do chart reviews to make sure that they actually are answering those questions and documenting it. The other nice thing about chart reviews is that they usually could be exempt from having to get IRB approval because you can say that it's a quality improvement project. So the next way to start an evaluation is to start with a pilot. And most every single study that I've ever done, we started with a pilot. And a pilot, it allows you to focus, it allows you to iterate, to try out an idea, to demonstrate that it's effective or that it was a total failure. And it allows you to generate buy-in from senior leadership. It seems non-threatening if you say, well, we're just going to try this out with 20 patients. It seems manageable. And then it allows you to work out some of the kinks. So one of the questions that we have for you guys is, how many of you guys have actually launched successful programs and started with pilots?
And for these questions, as Dayna moves forward with sort of sharing some of her examples of pilots, if you just wanted to share in the chat window what examples of pilots you've started at your agencies, then we can share those to the larger group once we see those come in. So please, again, share in the chat window an example of some of the pilots that you've been running at your agencies. Thanks.
So I want to talk about a really fun pilot that we actually did in 2013, which feels like it was forever from now. And we had an AmeriCorps, and she was working with us within our clinical setting, and we decided that we wanted to make sure that we actually were screening families and referring them to resources. And so we thought about, well, what's an easy win? Where could we actually start? So in April of 2013, this AmeriCorps, who you see in this picture, was sitting in the front desk, the front area of our clinic, and we were all focused on summer activities. We work in a pediatric clinic. And so we wanted to see, would families be interested in getting information from their pediatric clinic about family-based summer activities? And these include information about pools, about free days at the museum, story time at the library. And we wanted to sort of track families and see what their interest is. And just within a very brief 6-week period, we had over 200 families on their own walk up to the desk and say, yes, I'm interested in summer activities. And of those families, we actually selected randomly 100 of them to follow up with. And what we found is that a little less than half of those families that, in a very casual way, we asked about whether or not they'd be interested in these activities. Almost half of them actually registered, enrolled, and participated in that summer program. And when we reflected on that experience, we said, wow, this was such a low-cost, easy intervention, and families were very interested. And this summer pilot, it actually launched us to create an entire program. That program is a program that I founded and directed. It's called FIND. It stands for the Family Information and Navigation Desk, where we screen families for unmet needs. And now those unmet needs range from everything from summer activities to food, diapers, housing, transportation, mental health, child development. We refer them to community-based organizations. We provide the case management and follow-up, and then we're actually able to look at the data in a de-identified fashion and generate an entire population-level data set on what are the needs of our families. And it started with a very small, very simple, low-cost pilot. The other pilot that we're doing is on a very big, hot topic right now, and that topic is adverse childhood experiences. And most all of you on the phone have heard about ACEs. And what we know is that when children experience abuse, neglect, and household dysfunction early on in life before the 18th birthday, it can lead to poor health outcomes, such as obesity, diabetes, cancer, and depression. This initially was a study that was done at the Center for Disease Control and Kaiser Permanente in San Diego with mostly middle-aged men. It was a population that had Kaiser. And what they found is that if you had 4 or more ACEs, your risk for disease was exponentially higher, so that you had almost twice the amount of risk for things like cancer or diabetes, and almost 10 times the amount of risk for suicidal ideation or other mental health issues. And so when we were thinking about how, as a pediatric system, we could start to develop a prospective pediatric ACEs screening tool, we could pilot anticipatory guidance with families. I'm trying to click on to, there we go, and we could develop interventions. We said, okay, let's focus and let's start small. So we partnered with Dr. Nadine Burke-Harris, and we decided, well, first of all, we need to actually create a valid questionnaire that is prospective and based upon a pediatric study population. What are the questions that we want to ask? What are the tonality of those questions? And what do families think about them? So Dr. Burke-Harris and I started to work together. It was about 3 years ago, and we piloted a questionnaire, and we actually took apart every single question, and we piloted it with multiple different stakeholders, including families. And we said, what do you think about these questions? What do you think the question is actually asking? And is it appropriate for us as pediatricians to ask you these questions about your very young children, the majority of which are between 0 to 5? And what families told us is, oh yeah, these questions are impacting my life, they're important, and I want you to do something about it. We asked providers the same types of questions, and what providers told us is, yes, these questions are important, but I don't feel as if I have the capacity to answer the questions, and I don't have the time, I don't know what to do about the answers, and it feels a little awkward, and I'm not sure that families are going to want to answer them. And so based upon that pilot, we actually created a tool that, although we did face validation initially, we now are doing the statistical validation of that tool in a larger randomized controlled trial that is now ongoing. Because the pediatricians said to us, I don't know if I know what to do about the answers, we also decided that we had to launch into a pilot about anticipatory guidance. What are the scripts that we can give to pediatricians in order to talk to families about the ACEs screening? And again, we started by interviewing the providers and say, what do you want to say? What do you think about this item? And based upon that feedback, we developed anticipatory guidance scripts that are now part of that larger randomized controlled trial. We also wanted to address the pediatricians' questions about what do we do about it? And so we piloted different types of interventions to see what would be the uptake and feasibility. How do we actually build resilience? And now those interventions are also part of this larger randomized controlled trial. We couldn't have done the larger trial if we hadn't started with the pilot initially. And so the next amazing pilot is something that we're working on with the mayor's office in Oakland and a fantastic team there that's run by Amanda Feinstein, who works in the mayor's office, about how do we actually catapult an entire generation out of poverty. How do we actually look at these 2,200 Medicaid-eligible babies that are born within our city limits, and how do we actually help to secure their financial futures through helping to set up college savings accounts during the well-child visits for the first year of life for these babies, and then follow them longitudinally with the larger goal. But we need to start with a pilot to see what would families think about this program. What did they think about the types of questions that we wanted to ask? And so we launched into this pilot of not doing a full-blown study, but asking families the questions that were going to be used for the larger study, seeing how long it took for families and what were the barriers and where were the opportunities. So that pilot actually lasted about 4 to 5 months, and we just started into the larger trial for the Brilliant Baby program this past March. We needed the pilot in order to work out the kinks, and we also needed it to generate the buy-in from senior leadership and from the pediatricians.
And I just wanted to add, we did get one example in from Roanoke, just as another example of a pilot, and maybe we'll have more extension on exactly sort of the evaluation around it, but in Roanoke, they recently participated in an 18-month pilot that was sponsored by the Virginia Healthcare Initiative for a Pathways Hub to expand on population health partnerships between local hospitals and local safety net providers. And that pilot really included a home visiting model and community health workers to help implement an overall community-based care coordination system to address the social determinants of health. So that was done in Roanoke Valley and a part of their Pathways Hub program. Another example of a pilot.
Awesome. It's really interesting to me to see how many of these pilots then get rolled over into system change. And I don't think system change happens unless you can actually start small and then make it bigger. And I would love for someone in the audience to change my mind on that, but that's definitely what my experience has shown. So the other type of study that's often used in the social sector are observational studies. And observational study really draws on influences from a population where you aren't necessarily controlling the interventions. They're very real world. I like this cartoon on the bottom because an observational study is you really just see, okay, so what happens from this younger man as he grows up? Observational studies are usually very suitable to sort of these real-world pragmatic questions, and it's a great way often to start research. They can detect signals about benefits and risks. They can help to formulate hypotheses. They can inform clinical practice. And some examples of observational studies are, for instance, within Berkeley and now Oakland, we actually have a sales tax now on sugar-sweetened beverages, and that in vending machines we're not selling sugar-sweetened beverages. Because the Bay Area is really sort of ahead of the nation in thinking about the harmful effects of sugar, it's a great time to do an observational study on how does this policy actually affect the food intake of young people, and how does it actually affect, as these young people are growing up, their risk for things like hypertension and diabetes. Smoking bans is also a really good example to look at cities or counties that have banned smoking in public places and to see what are the observational effects on asthma rates in those cities. You can do the same thing on air quality. So within Oakland, we have sensors up throughout the city that look at the 5 most common indicators of poor air quality and pollution. And then we can see how the air quality actually changes healthcare utilization for asthma. Observational studies can be really challenging as well. And they can be challenging because you have a population and you can see that there are detrimental things happening in that community. And then it's an ethical issue about whether or not you continue to observe, or you actually see when you need to stop observing and actually deliver an intervention. The next type of really helpful impact work is something that we call human-centered design. And I know a lot of you are using human-centered design right now. And essentially, human-centered design is a process that starts with the people. It starts with the people that you're designing for, and it ends with new solutions that are tailored to addressing the needs of the people. It really comes in 3 different phases. And the first phase is this inspiration phase, where you learn directly from your stakeholders that you're designing for, that you immerse yourself sort of in their lives, and you come to deeply understand their needs. One of the landmark papers about human-centered design is called "The Anthropologist Walks Into the Bar." And the notion is that you immerse yourself in this environment and you just observe without making any kind of judgment or trying to direct your observations into any one place. The next phase is ideating, where you start to actually look at themes that are being generated and you identify opportunities for design and possible prototypes. And then you move on to the implementation phase. And the implementation phase is where you bring your solutions to life and to market, and you iterate quickly on that prototype until you actually get at the heart of what you're trying to do. More and more, as physicians, we're learning about this human-centered design work, and I actually think it's super fascinating. So I want to talk to you a little bit about how we've used human-centered design. And my question now for the audience is, how many folks have incorporated design thinking into their programming? So because of the work that we did with the pilot that I told you about, the summer pilot that had to deal with activities, we created this really robust cloud-based system called FindConnect, which we define as an innovative solution to help care teams collaboratively address social determinants of health. And it's focused on areas where families might be struggling with unmet basic social and environmental needs. As I mentioned, we talk about issues of food insecurity and housing instability, about not having adequate transportation, about being concerned about their child's development, about being concerned about parent or child's mental health issues. We talk about violence, we talk about discrimination, and it's heavy, hard stuff. We have a workforce that helps us with this type of screening and referral, and this workforce is made up of community navigators, community health workers, some of which are paid and some of which are volunteers. And in this human-centered design process, these navigators became our major stakeholder. And we worked with the Stanford Design School, and we had staff members from the design school come in and observe the work of the navigators. And it's hard. And what we realized is that even though we wanted to be, we weren't as strength-based as we hoped. And having a young person come into a patient room and immediately start asking about early childhood adversity or mental health issues, it was hard to necessarily facilitate that relationship, that trusting relationship, when you start off with things that are hard. So we decided, as a result of this design thinking, what if we start off with the good? What if we start off with focusing on the resiliency? And so then we did this pilot with the navigators with having them ask families, what does resiliency mean to you? What does it look like? Where do you find your joy? And as a result of that work, it was like magic. We would have navigators come in the room, and there would be a young child there and their caregiver, and they would say to the child, and these are children that are verbal, so 3 and up, what do you love the best about your mom, your dad, your uncle? And then we would have the caregiver answer the same question about their child. What are the great things about Malik? And then the navigator, through using algorithms and flows that we created, they would write down the answers, and we always create action plans for families. And action plans are where, we prioritize the social need, we connect families via geolocation and cultural humility to appropriate resources, and then the action plans give follow-up instructions. But now at the top of the action plan are the answers to these resiliency questions. And when we give them to families, it's a way for them to remember and for us to remember, oh yeah, Malik really loves it when his mother gives him a hug or when his mother reads a book to him. And as a result of this human-centered design, it really changed the way that we are strength-based and the way that we're designing our technology platform. So another methodology that we've used a lot is pretty simple, and it's this idea of pre and post. And so you only have one cohort of patients, but you actually capture that cohort and you ask them a bunch of questions, do a bunch of tests, and then you deliver an intervention, and then you ask them similar questions sort of after that intervention at designated points of time. So it's data on a cohort, and you may or may not have a comparison group. An example of when we used this pre and post methodology was in some work that we did with the Clinton Foundation on a program called Too Small to Fail. You can look up the program. It was super successful. It's toosmall.org. And we actually wanted to think about with families how you weave together a narrative about encouraging families to talk, read, and sing. And then we moved on from the talk, read, sing work to work on early numeracy and number sorting and shapes. We wanted to know at baseline how often were families in our community talking, reading, and singing to their kids, how by providing an intervention we could actually not only change practice, but also actually influence resiliency and improve child development. And so oftentimes research is so very simple. We calculated how many families we would need in order to power this study, and then we had research assistants go in and speak to families before the pediatrician went in and ask them simple questions. How often are you talking, reading, and singing to your child? Has the pediatrician talked to you about this before? The pediatrician then went in and developed an intervention, and this intervention was developed by the Too Small to Fail group, which included folks from a foundation called the Opportunity Institute, and co-designed with us from Children's Hospital Oakland, and it revolved around developmentally appropriate messaging about neuroplasticity, which is how your brain develops, and the importance of talking, reading, singing. The pediatricians had scripts, and they had toolkits. My slide changed by accident, there you go. And they had toolkits. And then after the pediatrician went in and delivered their intervention, that research assistant would come back into the room and say, hey, what do you remember the pediatrician telling you about talking, singing, and reading, or about early numeracy? The family then left for that day, and then at a designated set time, a couple weeks or a couple months later, whatever you want to design, we then recontacted the family and said, again, what do you remember was delivered to you during this intervention, and how often are you doing these activities? And then you compare the baseline to your follow-up sample. The other way that you can actually do generate great narrative information is by doing a qualitative study. And we've done a bunch of qualitative studies as well. And the way that the qualitative studies work is that you do a cognitive interview with your families. And then you actually write down verbatim sort of what the family says. And after you have a certain sample size of these narrative stories, you then look at the stories and you generate and you process the themes. And so for the Too Small to Fail work, there was this qualitative component, and the narratives actually really impressed us. We heard things such as, the book you gave us was the first book she ever got. She's getting smarter. We go out and buy her more books now. I've always talked, read, and sung to my kids, but I guess having the tools to remind me how to do it is great. It makes those things habits, not afterthoughts. They laugh a lot when we sing. He loves to sing. We do it together. I sing to him and he sings back. You guys can read these quotes, but they're really powerful. And oftentimes if you want to satisfy a funder, being able to have these quotes, it gives the numbers, the data, it gives it significance. So really the gold standard for research are randomized controlled trials. And randomization, it maximizes the power of a study. It helps to minimize some of the selection bias. And if you want to actually be as rigorous as possible, you do a randomized controlled trial. People are often intimidated by these randomized designs, and the truth of the matter is that they're completely doable, and you generate evidence that is much more undeniable. There are always ethical considerations, and some of those ethical considerations is that by nature, a randomized control study has a control group, a group where you withhold an intervention or they get the standard of care. So my question for the audience now is, how many folks on the line have actually been involved in randomized controlled trials? I feel as if in order to actually affect policy change, we need to make sure that our results are as rigorous as possible, and oftentimes being able to say that these results are statistically significant is really important in the discourse with policy. So I'm going to give you a couple examples of randomized controlled trials that I've been involved in. And so this is a study design from a randomized trial that we did in 2013 and 14 that was published in 2014 and sort of has led to some other studies. So this study was called the iScreen study, and it's a study that took place in our emergency department where we were first wading into the water. We were wanting to see what questions can we ask about social determinants of health. what are the questions, how are families going to feel about answering the questions, and what modality can we use in order to encourage families to answer the questions. And so we randomly approached families in the urgent care setting, and we randomized them to answer questions about social determinants of health either on a tablet that was programmed with an audio and visual in English and Spanish versus being asked the question by a bilingual bicultural navigator. We decided that we definitely wanted to make sure that we powered up our study, and so we approached over 700 families. And you can see from this table, this is a typical table for what a randomized controlled trial looks like. You can see that families were essentially equally randomized to using the tablet versus answering the questions in person. And what we found from this iScreen study are a lot of great process measures. And so the process measures, and these are cross-group, is that sadly what we found is that across modality, so whether it was the tablet or the in-person navigator, that almost 60% of our families were concerned about running out of food before they had money to buy more. You guys have to realize that this is a huge number. We also found that over 50% of our families were concerned about their child's safety in their neighborhood homes and schools. Almost half of our families were concerned about the mental health of the primary caregiver of the child, and a little less than half were concerned about the habitability of their housing. Disclosure rates were similar across groups within our randomized trial. And although families said that they actually prefer to answer the questions using a bilingual, bicultural navigator, especially for highly sensitive questions about domestic violence or immigration, overall disclosure rates were really similar, which led us to the conclusion that we should be doing more screening routinely for social determinants of health within our institution, and that we need to better be using technology in order to support that screening. If there are questions about any of these studies, please just enter them in the chat box and I'm happy to answer them. So that randomized trial actually led us to our follow-up randomized controlled trial where we sort of thought about the evidence that we generated. And what the evidence suggested is that we should be doing more screening for social determinants of health. That first trial, we had no interventions paired with it. We were just screening children and their caregivers. And so for the next randomized controlled trial, we wanted to actually expand the sites. And so we actually now had 4 sites that we were randomizing. And so it was primary care in Oakland, primary care in San Francisco, urgent care in Oakland, and then urgent care in San Francisco. And we wanted to actually pair our screening with 2 different types of interventions. And so the control group was a group that got screened, and then they were just given on paper information, general information about resources. The second group was actually screened, then paired with a navigator in order to provide a warm handoff to community-based organizations to do the referral and then to do the case management and the follow-up with these families. So in this randomized design, again, we wanted to make sure that we highly powered our study. And in order to power it, we approached over 4,000 families. They were randomized into 2 groups. And you could see, although we offered randomization in both locations, we actually ended up randomizing more families to the emergency department than we did to primary care. And then of those groups that were randomized by location, they were further randomized into this comparison group, which was given resources, versus the navigation group, which had the warm handoff, the referral, and the case management. When you randomize families, there's several different ways that you can do it. You can use a computer program to generate the randomization numbers for you. You can randomize by provider. You can randomize by site. You can randomize by days of the week. There's a lot of ways to do it. What we found from our study are that, one, we asked families, can you tell us how often you've been asked these questions before? And we sort of pride ourselves on being a really good academic institution, and yet even within our institution at the time, less than 17% of families reported that they were asked these questions before. And of those who said that they've been asked the questions, less than half ever received a referral for their non-medical needs. What we also were able to show in a statistically significant fashion is that in the intervention group that worked with navigators, we were able to resolve at least one unmet social need. And these social needs are needs like food insecurity, housing instability, the ability to keep the utilities on, the water running, and that in the intervention group where we resolved one unmet social need, we actually improved parent report of child health outcomes. So you guys, this was like the holy grail, right? That we statistically significantly showed that when you address social needs, you improve child health. One of the other points that is part of this federal triple aim that we wanted to prove is not only efficiency and reduced cost. You know, working with community health workers and navigators is much less expensive than developing a new medical device or immunization, right? And so if working with a community health worker can improve child health, that's a huge cost savings. But we also were able to show that we had super high levels of patient satisfaction. So again, we had a ton of process measures, and this is just the data from Children's Hospital Oakland, and it's looking at the overall needs within our community. And again, the amount of unmet needs in our population is much higher than what I often see reported in studies. For instance, in this study, we asked the question about running out of food, and over 40% of our families said that they're food insecure. And the needs range from, again, food insecurity, housing instability, the ability to pay utilities, et cetera. So these kinds of randomized trials have really helped to create sustainability within our institution. So now programs such as our community health worker program and our technology platform are now our standard of care. And that wouldn't have happened if we hadn't been so rigorous and intentional on generating the evidence to show that this was necessary for the way that we function and the way that we think of health. Another example of a randomized controlled trial that we're doing is called Food as Medicine. And the Food as Medicine program, it's in conjunction with a lot of our local government and our Board of Supervisors in order to look at how do, in this particular trial, how do food delivery programs to families that are at risk for either being obese or have diabetes, how does it actually change practice and clinical outcomes? And so this started as a small pilot for RCT, and now we're launching into a larger pilot this fall where we work with local farmers and the food bank in order to identify families who have children that had obesity or prediabetes. Local farmers worked with us to deliver these certified agricultural boxes to their home. We incorporated whole grains into those boxes, and we gave education to families about recipes and nutrition. There were 60 families who received this intervention, and what we found was really awesome, right? What we found is that not only did we significantly increase the amount of whole grains that families intake to twice what's recommended on an average daily basis, but we also statistically significantly dropped the fasting blood sugars of the parents of those children. And we also asked families about sustainability, and 2/3 of families said that they would use their EBT cards in order to continue the delivery of local produce from farmers. This study was really instrumental to us getting more funding to actually look at our broader population within our ambulatory care setting of families that are food insecure, seeing if we can actually bring food to where the families are and if we can help to eradicate food insecurity within our patient population. So whenever you think about studies, you want to think about what is your North Star, right? What are the long-term outcomes that you want to achieve? And it's most helpful for me to think about what are those longer-term visions of what you're trying to achieve, and then to back into them. So to start with the long-term indicators, I want to impact child health. I want to impact healthcare delivery utilization. I want to influence kindergarten readiness or third grade reading level. And then think about, okay, that's my long-term goal. And now, what are the short and mid-term indicators that will help me know that I'm actually achieving that North Star? And so process indicators, and I alluded to some of these as I was going through the slides. Process indicators are how many people did you reach? How many did you screen? How many did you refer? How many did you help to get federal benefits such as food stamps? How many families did you follow up with? How many referrals did you make? Immediate indicators are, what was the impact? Did you actually resolve that need that you set out to? Patient satisfaction is an intermediate indicator, as well as asking about patient-centered outcomes are also intermediate indicators. Tiffany, I've seen some things pop up in my chat box, so feel free to interrupt me.
We just got some more updates actually from the Roanoke Group, sort of talking about how that pilot turned out as far as an evaluation. But I think it sort of fits in nicely to sort of what you're talking about right now, so I can share that with you. That the pilot that we shared earlier, the real intent was to reduce the high utilization of the emergency room and reduce the cost that comes along with that. And they were particularly by people who meet specific requirements. And so that model provided various benchmarks and outcomes along the way that they were using for evaluation. And after the 18-month pilot, they showed they were able to save about $500,000. And so the hub has continued to be funded by the United Way there. And they're fully implementing that program now. So we appreciate, thank you so much for sharing that, Antoine from Roanoke. We've got a document about that whole process too that we can share with a larger group after the webinar as well.
Great. And so when we start to think about the types of outcomes, the long-term outcomes that we wanted to measure, for me, I've needed a framework in order to actually sort of write down and organize my thoughts. And the framework that I've landed on is this concept of a logic model or a theory of change. And I know a lot of you have been using these types of logic models, but you think about sort of what are those long-term goals, what are the medium and short-term indicators to know that you've actually reached there, and then to actually think about what are your inputs, and so what do you have that you're going to be putting into this program, and then what are the outputs. This is a really great model to use when you're doing study design, and I actually think that for every single program that I mentioned, we start with our theory of change. So what does it take? What does it take to actually pull off a research project? And it's a lot of work. I'm not going to lie. It is blood, sweat, and tears, and it's essential, I feel. And so the first question to ask yourself is, do I need to actually get approved through an academic institution, through an IRB, an Institutional Review Board, or will this be exempt as a quality improvement project? If you have an IRB that you're working with, those IRB applications can take quite a while, and you need to make sure that when you think about what your scope of work is, that you leave enough time to not only submit to the IRB, but the review processes by the board itself can take weeks or months, and then oftentimes they'll come back to you because they'll want you to make changes. So make sure you leave enough time for that IRB. The buy-in has to come from the bottom up as well as the top down. If you don't have the staff that's on the ground actually supporting the research and program, it's not going to happen. And that staff ranges from everybody. It ranges to everyone that touches that patient or that client. And so it's the folks at registration and the front desk and the MAs and the LVNs and the community health workers. Every single person needs to get bought in and feel as if, yeah, I'm doing this and it's going to make a difference. And then, of course, you also need senior leadership, whether it's the president or the CEO or the executive director, the nurse manager, to also buy in. It's super important to make a budget, and in that budget, people's time is not free, and unless they have dedicated time to meet and to work with the data, you're not going to be successful. So to make sure that you're actually compensating people for their time, and then you have the infrastructure, the capacity to actually make this happen. And that includes highly trained, really good research assistants, program managers, and then program champions. So this picture is an example of some of the research assistants that I have. And I took some classes at the Harvard Macy's Institute, and what I learned from these business classes is that you have to make sure that you have the right people on the bus, right? You need to have people that, in my case, because we work with such a diverse population, I need my researchers to speak the same language as the patients, and so we have research assistants that speak English, Spanish, Arabic, Mandarin, Cantonese, Spanish. They need to be able to develop trusting relationships. They need to be central parts of the team. Again, they need to be diverse, and they also need to be able to use whatever technology and data tool your research project is utilizing. I realize that we're a little over the hour, and so I'm going to continue just to go through these last couple slides, and then I'm happy to stay on the line. It's also really important to have an integrative data system that's HIPAA compliant. When we first started these studies, we were using paper, and even still, the consent, it's on paper because families have to sign it, and then we have to Xerox it, and we have to give families a copy of the consent. So no matter how technologically savvy we are, we still use paper. For some of the quality improvement projects, such as if you want to survey staff on a particular question, you can actually use something like SurveyMonkey. Our initial RCTs, we actually used Excel to track families, and now as a research tools, we use either Qualtrics or REDCap. We do report writing within our EMR, and then we created this FindConnect system. And the FindConnect system is the system that helps us with the screening, referral, case management, and then we're able to create logistical reports using this FindConnect platform. And I'm going to show you an example of what that looks like. So here's an example of what FindConnect can do. And so the navigators use this tool that we created in order to do the screening, referral, and case management. And then the system itself can aggregate and de-identify the data and give us population heat maps so that we can see where our patients are coming from that are enrolled in the study, and then stratify them based upon need, on age, on race, etc. So the lessons that I've learned from doing research are really extensive. More and more, I think that we're gaining an understanding of the impact of social determinants on patients' health, and we're realizing that trauma and adversity, these system factors, are actually what leads to higher rates of disease, particularly in low-income communities. We're learning that effective population health really requires universal screening and data management. I've had to work so far outside of my sector, and that takes, as I said, a lot of bravery and vulnerability and an ability to admit, you know what, I don't know the answer to this, but let me ask someone in the business world. Let me ask someone in the educational world or in government. The human-centered design piece cannot be underestimated. It's really important to listen and to listen closely to what your population needs. And this draws from the lessons of cultural humility, which teach us that we need to listen with our entire bodies and that we can't make assumptions. We have to listen knowing that the speaker is wise. We have to allow ourselves to iterate and allow ourselves to fail. There have been projects that I thought were great ideas that didn't work at all. And to me, those failures are successes because I learned to do it better the next time. We always want to think about sustainability when we're designing a project, because the whole goal of research is that it can jump this chiasm between just a research finding to really transforming clinical practice. And I've also learned that it's very important to be transparent and to be clear. What is the role and responsibility of every single team member and to hold people accountable. So my North Star, when I think about what my sort of long-term outcome is, it's really to disrupt this link between adversity and poor health. And how do we actually create buffers for our families so that every single child can reach their optimum potential? So I'm going to turn it over to you, Tiffany.
A great information across the board, and I think so that's definitely something that any agency at any level of implementation can take something away from. We haven't had too many questions come in, but I do want to give people an opportunity now that we've heard all of the information. If there is something in particular that you're looking for, or something that Dayna mentioned that you want her to expand a little bit more on, please feel free to put that in the chat box, and know that Dayna is ready to provide more information. She really is here to help you guys where you're at now. So please feel comfortable sharing to all of us, because your peers are also in a similar boat. But we do have one comment from Michelle Fields that she said it was a great presentation. So I'm hoping that that was a shared experience. I know that we definitely got a lot of takeaways here at the national office that we want to share with other people. So please feel free to chip in, anybody, about any questions you might have. We'll definitely also share some of these resources that you mentioned along the way, so people can use those. And so we've got something coming in the Q&A. Oh, again, another confirmation about how all of the information that you shared and how helpful it was. We do have a question from Kim in White Earth. She's asking us to share the algorithm and action plan template. Is that something that you have in a shareable format, Dayna?
Yeah, what I would say, if it's all right with you, Tiffany, is that to those participants, if you can share my contact information, and then I'm happy to follow up with them.
Absolutely, we can do that. Let's see, great information. Another question is, how can we cultivate input in using and applying the resources shared? So I guess that you can, because Dayna's going to be sharing her contact information, she can sort of directly exchange with her about how some of the resources she shared can be more applicable to your situation. Again, we post a lot of this information on and actually I'm going to review that in a second, on our blog, on our website. We're using something called the Learning Community Academy, which is using the Moodle platform, so that gives you a little bit more ability to interact with the resources and interact with other action agencies that are interested in the same content. So I would encourage you guys to go visit the Moodle Learning Community Action Academy site as well. But I'm sure that Dayna is happy to also work with you if you have some direct questions for her. Let's see, anything else that you've come through? Doesn't seem like there's anything else. Did you have anything else that you wanted to add now that you're getting some of these questions about resources and using them? Any recommendations for how people can access them beyond how we share them?
Yeah, so there's a ton of resources, whether it's the studies that I mentioned. I'm happy to actually send them to you, Tiffany, if people actually want to read the publications from some of those studies. If people are interested in the Find Connect platform, I'm happy to give the website for that. And if people just want to bounce ideas off of me about projects that you're thinking of, I'm happy to be a thought partner with you, and you can just email me directly, and Tiffany, you can provide my contact.
Thank you so much, Dayna. It was really, really helpful. We're getting definitely a lot of feedback from a lot of people who are saying that it was very informative. So we really, really appreciate everything that you provided today, and then all the other, and just being so available even beyond the webinar. It's a huge help, and it's really great to integrate this kind of work into the work of community action. They're so connected, health overall health and the work of community action. They're basically one and the same. And so it's helpful having somebody from your field sort of lead the way and for all of our agencies to really start thinking and implementing and evaluating these programs. So I'll move forward. You're welcome to stay on, Dayna, just in case any other questions come up. I'll just kind of review some of the things we have coming up, the places you can go to find resources from this learning community and others. So right here we've got our blog. If you go to lcrcweb.com, we share all of the recordings of the webinars that we offer, as well as the presentation slides, and also share resources that were mentioned in the webinars as well. So some of those studies that Dayna mentioned, we'll try and make sure they're posted on that blog too. And there's a few other things that we have there on an ongoing basis, some like fresh resources from the field, and different opportunities to engage with other agencies. So I encourage you all to visit the blog. There's also the CSDG TNTA Resource Center, sort of a general resource library for everything related to CSDG. You can always visit that resource center. And then this is the Community Action Academy Moodle site that I was mentioning. So you'd have to create an account on Moodle, but there's an opportunity to have more sort of in-depth learning opportunities, homework, so you could follow along some of the learning community groups, and a lot of the information and presentations that we offer generally are also shared on the Community Action Academy. So definitely encourage you to join, and you can join the Health Intersections group. That's where you can take a deeper dive into some of this stuff related to health intersections. And then this, of course, today is a part of our larger Webinar Wednesdays series, where we offer a knowledge building webinar every Wednesday connected to any of those learning community groups that you saw in the beginning that Tiffany presented. So every Wednesday, 2 o'clock, we'll be here, just to make it easy for you. But just to give you a little bit of an idea of what's coming up, this is what we have this summer. In July, we'll be having a webinar focused on whole family approaches, collective impact webinar, another financial empowerment, and another integrated services webinar in early August. So please stay tuned to see our full calendar. You can go to the website and any of those other sources to see what else is coming up. And then, of course, it's summertime, and our conference is right around the corner, August 28th to the 31st in Denver this year. We have more hands-on presentations from all of our subject matter experts relating to our learning community topics. So we are looking forward to going to Denver and seeing you all there. And please register for that, because that should be a great event. And this is our contact information, so please feel free to contact any of us. We can get you in touch with Dayna as well. I will write in the chat box Dayna's contact information for everyone, or we will actually, I think the best way is we'll include that in our follow-up email for everybody. So I think that's it for today. We appreciate all of your attention, and Dayna, if you have any last words, let us know.
No, my last words are just that I want you guys to make sure that you're evaluating your programs as much as possible, and that it's really hard work, but totally worth it.
Great, thanks, Dayna. We've made it a little bit easier for everyone to do that with all of the information you shared today. And this definitely fits into this community action way of the ROMA cycle and some of the organizational standards. So what you offer today really helps agencies do that a little bit better. So thank you so much, and we'll see you guys all soon, and we'll be following up with all the resources that we mentioned. Thank you.